عفوا خلينا نكمل الجزء الثاني. So we were talking about the lab diagnosis for Clostridium perfringens. So you can do microscopy of the exudates of the wound, because this is for the wound one. You can take this and you can see, you can do gram stain. You can see the large gram-positive rods. Do you see the spores? No. Why? Because now they are in a nutrition. They are formed only under a nutrition deficient condition. So this is a good condition. So the spores are germinated. The organisms are cultured anaerobically. كل الكلوستريديوم صعوبتها في الكلتشر هي to be able to capture it and transport it and maintain the transport under anaerobic condition. إذا حطيتها بتيوب عادي راح يكون كله أكسجين، راح تقتل البكتيريا, so it will not grow. بس تذكروا كنا نحكي if you want to increase the sensitivity, you want to capture your organism, you need to be able to grow it. If you don't grow it, you're going to report it as negative, as no growth. So it needs to be cultured anaerobically and then identified by sugar fermentation reactions, and then there are some organic acid production. They exhibit double zone of hemolysis on blood agar. Egg yolk agar is also used to demonstrate the presence of lecithinase, lecithinase, and then serology might also, they're not really that useful. But this is from a wound. You can see the gram positive rods in here. Treatment and prevention. So penicillin G is the antibiotic choice of treatment and prevention. إذا لاحظتوا إلى الآن ما حكينا عن any antibiotic resistance or any significant resistance for these gram-positive rods. So wounds should be debrided. So my problem is not the antibiotic. My problem is شو مشكلتي معهم أنا؟ مشكلتي معهم الtoxins. That's the problem. So antibiotics don't really help me in this manner. So wounds should be debridement, and treatment should be started with a prophylactic option. Food poisoning caused by Clostridium perfringens transmission. بيحكي لك هنا heat resistant spores survive cooking and they germinate. Obviously these are spores, بدك autoclave لتقتلهم. So regular heat in cooking will not kill them. So the organism will grow into large numbers in reheated food, especially meat dishes. So the story here is slightly close to that of Bacillus cereus, but meat dishes are more common in this effect. Clostridium perfringens is a member of the normal flora of the colon, but not in the small bowel, so only in the colon, where the enterotoxin will act to cause diarrhea on the small bowel. That's where the majority of the water is released, in the small bowel. The mode of action is the same as that of the enterotoxin and the exotoxin 2 of the Bacillus cereus, is that it acts as a superantigen and causes a profound release of interleukins. Clinical findings: the disease has 8 to 16 incubation period. معناتها راح يكون في vomiting. It will be little vomiting. Why? Because you have bypassed the 4-hour mark for the stomach. So past that is the incubation period. That's where it is in the small intestine. So the diarrhea is watery, lots of cramps. Cramps عادة بتعرفوا ليش? Because you have this abnormal spastic movement of the colon and the small intestine. So basically here incubation period is the time for it to reach زي ما حكينا in the small bowel. It is spontaneously, again زي Bacillus cereus, it spontaneously is resolved within a day or two. Lab diagnosis ما في إشي. Again this is just supportive treatment. Again نفس القصة, بتخاف من electrolyte imbalance and fluid imbalance. So that's the only thing that you worry about. Prevention is you want to adequately cook food. Reheating is not good. هلا خلينا ندخل شوي نحكي بهالقصة إنه مثلا الرز المسخن. انتوا في بيوتكم بنسخنوا الرز، فكروا فيها كلنا بنسخن رز. شو هو البرياني؟ البرياني عبارة عن بالهند عبارة عن رز مسخن. فرايد رايس، شو الفرايد رايس؟ عبارة عن رز مسخن. هذا بالصين. دول العظمى، يعني مش دول العظمى هذا دول العظمى بالعدد، يعني الهند، القارة الهندية، الصين، أعداد هائلة كلها بتستخدم reheated rice, fried rice, biryani, واحنا كمان يعني احنا بجوز ما بنسخن الرز عاده باكلنا، انه عاده احنا نعمل يوم بيوم. بس بحكي لك adequate cooking of food. الرز، اللحمه it has to be adequately reheated. لكن عشان انت تضلك بالسليم you have to say that reheating will germinate the spores and then produce exotoxins which will cause the diarrhea. Adequate cooking. هل adequate cooking بيقتل الspores? No. Adequate cooking will destroy the heat labile peptides. That's it. So especially good reheating. فبدك يعني to cook the food if it has to must عادة هم عندهم this is a folklore يعني إنه مثلا when you heat the rice it has to steam يعني معناته يوصل درجة حرارة 100 otherwise فهذا obviously will destroy any peptides that is present there. بس إحنا كأطباء أنت عشان شو بنحكي إحنا we usually say for rice استخدم الرز إذا بدك تعمل اطبخ الرز اللي بدك تاكله بهذا اليوم do not keep it for the next day is better. يعني كل الرز أول بأول بيكون أفضل. And then if reheated food, meat, whatever, it has to be at least it reaches a very high temperature. So adequate cooking. Clostridium difficile. Clostridium difficile, this one is the one that causes antibiotic associated pseudomembranous colitis. We mentioned how all these broad spectrum antibiotics can destabilize normal flora, which once they are gone حكينا إذا في بكتيريا اختفت هذا النيش ما بصير sterile، راح تيجي إشي مكان تاني هيجي محله. Always there's another bacteria that is waiting to fill the gap or fill the seat. بالcolon إذا if you happen to be a carrier of C. diff and then that person is given a broad spectrum antibiotic مثلا tetracycline، أخذ doxycycline، أخذ مثلا third generation cephalosporin، أخذ all هالأشياء اللي حكيناهم بمحاضرة اللي رجعوا لها محاضرة الأنتيبيوتيك. all these broad spectrums كلياتهم even certain penicillins will cause destabilization of the flora and then this carrier will become growth. أو مثلا إمتى إذا ما كان carrier بالمستشفى، هو قاعد بالمستشفى بياخذ مضادات حيوية his flora is already empty لأنه قاعد بياخذ مضادات حيوية ما في إشي بالفلورا، the tiniest amount of C. diff تدخل على جسمه it will overgrow because it is usually resistant to these broad spectrum antibiotics and then it will cause pseudomembranous colitis. فهي الحالتين بني آدم بالكوميونتي أخذ مضادات حيوية هو كارير، بني آدم مش كارير كان بالهوسبيتال أخذ مضادات حيوية and then was infected by the hospital staff or patients or whatever. So remember this is caused primarily by the overuse of broad spectrum antibiotics. So this is what it looks like if you do colonoscopy. Yellowish plaque like lesions in the colon. It is caused, again, this is a gram-positive Clostridia. This is an exotoxin production of C. diff exotoxin that inhibits signal transduction of protein and causes the death of these enterocytes. Transmission 3% 3% in the community and 30% in hospitalized patients. So you would think it is higher in the community. الأعداد numbers are higher in the community, might be. Why? Because 3% of all the community is much larger than 30% of the population of people in hospitals. So, but 30% in hospitalized patients is a very high number. وهدول اللي بيطلعوا those patients who come into the hospital, they become حتى even if they don't get pseudomembranous colitis, they are now carriers for the future. So since 97% of people are not colonized, they will not develop pseudomembranous colitis. In the hospital, 30% will become a risk even after the use later on, even after they are discharged. And years later, they are given, if they do not re-establish their normal flora, if they are given antibiotic, they might be susceptible to having pseudomembranous colitis. The actual transmission is fecal-oral. So this is a gross break in hygiene that can cause, and the hands of the personnel in the hospital is the main problem. This is why prevention is the trump in the in combating C. diff. So before giving antibiotics, قبل هيك, the more likely is I want to reduce the carriage rate. This is done by prevention mainly. So pathogenesis, antibiotics suppress the drug-sensitive flora, and then C. diff will multiply, producing its exotoxins. What are these exotoxins? There is exotoxin A and B. Both are glucosyltransferases. The glycosylate rho GTPases. This is a very common mechanism for acting on the elements that regulate the cytoskeleton of the cell. So rho GTPases راح تشوفوها. This is a common one. And then the main effect of exotoxin B is in particular to cause depolymerization of actin, resulting in the death of enterocytes. So if you recall, حكينا metronidazole, clindamycin. These are what we use عادة. Before metronidazole, we were saying that clindamycin is one of your first antibiotics that you use to destroy anaerobes. Clostridium is an anaerobe, but Clostridium may be more resistant than other anaerobes to clindamycin. So if you use clindamycin, this is the first antibiotic that was linked to pseudomembranous colitis. Giving clindamycin has killed other anaerobes. So the anaerobe that takes over will become C. diff. And then you will have, this is the first antibiotic that was used. Third generation cephalosporin حكينا because it targets gram negatives and anaerobes. So here is a common pattern is targeting other anaerobes other than C. diff will cause C. diff to overgrow. Ampicillin, fluoroquinolones, antibiotics, even cancer chemotherapy also predispose to this, because even cancer chemotherapeutic agents can also affect the membranous, the flora, and then can cause or even predispose patients, زي ما حكينا, by destabilization of the normal flora to predispose patients to pseudomembranous colitis. So C. diff rarely invades the intestinal mucosa, it remains within the mucosa. Clinical findings. What do you see with a patient with C. diff? So they will have diarrhea, it's not invasive, so non-bloody. Lots of neutrophils are seen because lots of neutrophils from the Th17 response will try to invade and then prevent the invasion of these bacteria. So this will develop a lot of pseudomembranes, these yellow-white plaques that are seen in the colonoscopy. And then fever, abdominal pain will ensue. The very feared complication of C. diff is called toxic megacolon, an enlarged, swollen colon that is no longer functioning. It is toxic, it has overgrowth of bacteria, it will lead to the patient's death, and this is treated by surgical resection of the colon, may be necessary in extreme cases. So to differentiate this from any transient post-antibiotic therapy C. diff, toxin must be isolated in the stool. What are we saying? Do patients have diarrhea? If you open the leaflets of many antibiotics that you give, you will see nausea, vomiting even, and some cases diarrhea are common side effects. So this is just regular transient post-antibiotic therapy diarrhea that self-resolves once the restabilization or rebalance of the normal flora is established. Membranous colitis, you have to show that C. diff is present, and you do that by doing an assay that screens the stool for the toxin, the exotoxin. So lab diagnosis, basically you will filter the stool for this exotoxin to establish diagnosis. We can't only depend on the culture, so due to the fact some people are asymptomatic carrier, so they might have it, but there is no production of the exotoxin, there's no overgrowth of this bacteria. It would take time to link the culture to exotoxin dust, and this is why we just go for the exotoxin right away. So detection, how do you detect it? You can coat your ELISA plates with an antibody for this, and then you can put the filtered stool, and you can see if you have the exotoxin in the test. So, and this is a rapid, very less sensitive than cytotoxicity test. Cytotoxicity test, we use the cultured human cells, and then we expose them to the filtrate, and then we see if there is destabilization of the actin filament. معناته التوكسين موجود. And this is more sensitive and even more specific, but it can take times because you need to grow the cells, you need to then expose them, and then you need to observe. It takes time, it takes about 2 to 3 days to do this. So you usually go for the ELISA. If you get your answer, if you don't get your answer, you still have a clinical picture. you might go for the cytotoxicity test, but at that point you have already crossed some miles in combating the bug. So you may have given him some antibiotics, and so might reduce uh, specificity. So what do? We can do PCR. If you can detect the gene of the exotoxin, which is unique for this bacteria, that can also be diagnostic. So ELISA, what it looks like. Treatment, what do you use? Antibiotics to treat the antibiotics that is causing the diarrhea should be stopped. And then replaced with metronidazole and vancomycin. Vancomycin is good for, why? Because this is a gram positive. واحد. رقم اثنين, we are worried about if I give metronidazole, I might have vancomycin resistant. I have my overgrowth of other bacteria. So you can give vancomycin, but again, you might worry about vancomycin resistance, that it might, because you are now exposing his enterococci to vancomycin. Then again, diarrhea, you need to replace fluids and electrolytes. However, in life-threatening cases, vancomycin here, where we can be used because it's more effective, because this is a gram-positive organism and is more sensitive to. Because if you want to target lots of anaerobes might be targeted, but if you give vancomycin, you will target this specific anaerobe more than others, and that will tip the scale towards other anaerobes, which they will take over, and then you can treat this bug. Carrier state is not removed but in many patients. هلا بنحكي عن هاي القصة. ديفيسيد, حكينا عن ديفيسيد في دوكسو عفوا في دوكسوميسين. It's called deficit. This is just an easy way to say deficit is the both treatment and preventative measure for this. فهلا وجدوا, because C. diff is C. diff is a very major problem in hospitals. C. diff is a very energy and resource consuming problem. So there's a lot of ways that we're trying to approach this, and one of this is called fecal bacteriotherapy, which is you go to a patient who has normal flora, and then you destabilize the patient's normal flora وتعطيه transplant. It's called a fecal transplant. I know this might sound funny. Take feces from a normal patient and then seed it in the abnormal patient's colon, and this stool will carry all the normal bacteria, and this is a very effective mechanism to reseed or re-establish balance in someone's destabilized normal flora or colon. This obviously can carry risk. He might have bacteria. The donor might have bacteria that are antibiotic resistant, might have even C. diff. They might have other things. So there's a lot of major safety concerns in this. So one might say, why don't we just give food? Why don't we just use lots of food that is rich in مثلا good bacteria, مثلا dairy food, food that is fermented food, vinegars, all that we mentioned. That actually also helps, but you need to maintain the diet over time. You can't stop the diet, because if you stop the diet, then the numbers of this good bacteria gets reduced. So you need to re-establish. So once the patient is born, بتعرفوا انه the colon sterile, and then they get their colostrum from the mother, and then the colon is coated with the good bacteria. Once that bacteria is gone, there's no way to bring it back. So in diet, you only replace the lost numbers, and that's it. So prevention, we don't have vaccines, unfortunately, or any antimicrobial other than Difficid. So especially in hospital settings, becoming a standard approach to prevent this carriage from staff to patients. So hand washing. دير بالك انت, especially when you are practicing, مثلا انت طبيب امتياز, مقيم, whatever, you are taking patients, you are helping patients. So I know you will be overextended وتعبان whatever, and you might خاصة مثلا in our hospitals, you might not find many stations where you can sterilize your hands. So but I promise you, this is a very, very big problem, and it's a one of the great things that you can do is to maintain your hands clean and your stethoscope knee, your whatever, everything that you use on the patient's clean. So probiotics حكينا lactobacillus, bifidobacterium, yeast, Saccharomyces may be useful to prevent pseudomembranous colitis. تمام. Now let's go to the non-spore formers. Now non-spore formers, we have two, Corynebacterium diphtheria, and then we have Listeria monocytogenes. We will talk about them both. So now, so far, we covered of the meningitis causing organisms. We covered strep pneumonia الثانية that might cause meningitis. حكينا of the gram positive rods اللي هي Listeria. بعدين بنحكي بالجرام نيجاتيف كوكساي اللي هي meningococcus, gram negative rods اللي هي الهيموفيلس. and then in yeast كنا بنحكي عن اللي هي كريبتوكوكس. تمام. وين كنا احنا؟ اوكي. So diphtheria toxigenic, Listeria pyogenic, but you will see Listeria has a unique mechanism that makes it so. Listeria has a unique mechanism. Even though it's pyogenic, it actually jumps itself, not sends the toxin, itself jumps and cause pathogenesis. So in a sense, all pathogenesis of gram-positive rods is caused by release of someone. Here are the toxin or the actual bacteria into the cells. So for diphtheria, what is the disease? Diphtheria, what is disease? What is the predisposing factor? Is to not be immunized. It's part of this, the DTaP. Yes, okay. So mode of prevention here, diphtheria has a toxin. Listeria does not have a vaccine. So prevention offered is a vaccine. Here does not have a vaccine, so you need to pasteurize milk products. Be careful with using non-pasteurized milk products. So let's go fill in some details. Corynebacterium diphtheria causes diphtheria. Okay, there are other Corynebacterium species, diphtheroid, that are implicated in opportunistic infections. You will see diphtheroids that don't cause diphtheria, the disease diphtheria, but are present as opportunistic infections. So what does it cause? Diphtheria. It is now approaching history of medicine rather than something that you will see. But because of wars, because of lots of countries not being able to vaccinate their children, we are actually seeing lots of these on the rise. We also are seeing, because in some communities they have this anti-vaccine movement, which also brings back older diseases. So you need to be wary of this. So diphtheria, this whitish gray pseudomembrane, what you need to know, do not remove it, do not touch it. It will cause a spasm and might even kill the patient because of the spasm of the larynx. So it is this is gray pseudomembrane that covers the posterior pharynx. Lots of inflammation. How red it is. This is very, very red. So this is very high inflamed and caused by the toxin, an exotoxin. This is a gram-positive rod. What does it do? This one inhibits elongation factor 2, and then we will talk about this in a minute. So important properties. Corynebacterium diphtheroids and diphtheria, all of them, they are club-shaped gram-positive rods. They are relaxed more, so they might be V or L-shaped, and they are arranged in Chinese letter patterns like this. So if you look at them from far away, they are all arranged in sort of a random manner, so they can look like Chinese letters. But some of them might arrange themselves as a palisade. هذا هو palisade. So it's like wooden stakes that are used as a fence. So they might arrange themselves like this. This is called a palisade pattern. They have a beaded appearance. Obviously, this is because of their granules حكينا عنهم that give them the club shape. And these are called metachromatic granules. That term can show up in exams, license exams. Club-shaped gram-positive rods, Corynebacterium diphtheria. This is what it looks like. Transmission: humans are the only natural host of diphtheria. So diphtheria to diphtheria, person who has it will give it to others. How? With respiratory droplets. Both toxigenic and non-toxigenic organisms reside in the upper pharynx and the respiratory tract of the patient, and then by coughing and other mechanisms, these droplets can be transmitted to other people. The organism can also infect the skin, especially at the site of a pre-existing skin lesion. And then this happens more in the tropics, where indigent people might have more skin lesions, and then they have less hygiene, and then they might have these lesions. Pathogenesis, again, this is an exotoxin-mediated disease. So the bug must establish itself in the throat first. It is there, it is invasive, then it sits, and then it starts producing the exotoxin. So this is where it sits and makes its gray membrane. And then from there, it produces this exotoxin, which inhibits the protein synthesis. How? It does ADP ribosylation of elongation factor 2, which you know from your biology, for elongation of the peptides. So there's no more peptides being produced. This is cidal. This destroys the cells. No more protein production. The cells start to kill. And again, this toxin is formed in a AB fashion, active binding fashion. So this is A toxin, A subunit, B subunit. So the toxin is encoded by a gene transmitted by, again, a phage here, as many toxins are transmitted. So how does the host respond to this exotoxin? First, a very prominent inflammation of the throat, which after a while produces this fibrinous exudates that solidifies to make this gray pseudo membrane. And then antibodies are produced against the exotoxin, which hinder the exotoxin by blocking its interaction with the domain, and who would be in the AB configuration. This is the binding. If you prevent binding for all toxins, including this one, then you prevent its action on cells. So with the receptor, no binding, no cell entry, no function. What are the clinical findings, complications? So diphtheria is rare due to vaccines, حكينا. However, we should be aware of the thick throat pseudomembrane. Other aspects, non-specific fever, sore throat, cervical adenopathy. There are 3 prominent complications. So if this membrane extends into the larynx and the trachea, it can obstruct it, and this is a very big problem. Myocarditis, this can happen. So we are talking about children that might have damage to their heart, and then arrhythmias, which might precipitate circulatory collapse. And this is due to the action of the exotoxin. So heart, nerves as well, nerve weakness or paralysis, especially of the cranial nerves, can also ensue. Paralysis of the muscle of the soft palate and pharynx can also lead to regurgitation of fluids. So they are drinking, they can't swallow well because of this muscle paralysis. Nerves in the periphery can also be affected. Again, we mentioned how the ulcerating skin lesions may be covered by the same pseudomembrane, gray pseudomembrane. But luckily, those do not invade the surrounding tissue. So for lab diagnosis, how do we know if someone has diphtheria? In regular situations, if you are talking about 30, 40 years ago, it was really just done by clinical suspicion. Just that would be it. But now because now you need to establish, you need to make sure what you have is what it is. The very first thing that you do is the growth of this on Loeffler's media. This is one of the media that you need to know for exams. They ask about this. So this is one of the special media. واحد اسمه Tellurite media, Loeffler's media. So there's clear cream-colored colonies in the slant, or Tellurite plate, which can give black colonies due to the tellurium salt that is reduced to, you don't need to know this, but you need to know is that it produces black colonies on Tellurite plate. Okay. It's usually also this typical gray-black color of the colonies is a very important diagnostic criterion. This again shows up in exams. Okay, so if the diphtheria is recovered from the cultures, we can confirm the toxin from the culture itself. So we can inoculate animals, and then you can do an antibody-based methylene diffusion test. or PCR for the presence of the actual gene. So that's what it looks like, these black colonies on tellurite plate. This is Loeffler, the cream colored colonies on the Loeffler media. Smears of the throat swab can be also stained with both gram stains and then methylene blue, which will show the diagnosis of diphtheria. The diagnosis cannot be made by examination of the smear because of lots of other diphtheroids that can look like diphtheria. So if you see it on the gram stain, that doesn't really help you. But the methylene blue stain is excellent for revealing اللي هم metachromatic granules. This can just give you direction more than diagnosis. Treatment. How do you treat it? Again, this is an exotoxin. This is a gram-positive rod. So your main option is the treatment with the antitoxin. So you treat the choice is the treatment of choice again is the antitoxin. You have to give it on clinical impression, just suspicion alone. On the clinical suspicion alone, you can begin the treatment of the antitoxin. Again, the clinical picture is very easy. So child, membrane, hyperemic, throat, هلا نحكي كمان أشياء so feverish maybe. So with the other consequences كل هدول مع بعض you can just alone with this start your treatment with the antitoxin, and that will not hurt. So if you give someone an antitoxin, they don't have the toxin, it would not hurt unless the antitoxin is made in a horse or mouse or whatever, and that can cause serum sickness. But that's the thing. That's it. Need for immediate treatment is due to the toxin's rapid, important, and irreversible action on the elongation factor 2. So these cells will not we'll come back to all these cells, the neurons, all these cells. If they are destroyed, you cannot get them back. So the other option which you have is in this case it is recommended is to use penicillin or erythromycin. Again, this is a gram-positive, so with the antitoxin, but not as a substitute. You cannot, because again, antibiotics do not work on toxins. So you want to reduce the bacterial count, reduce toxin production, but you still have to give the antitoxin for the already established toxin. Prevention, again, this is part of the DTaP. So this is the diphtheria and the DTaP. So it's given as part of the vaccine. In war zones, حكينا labs and immunization re-emergence is happening. So formaldehyde treatment of the toxin destroys the toxin but leaves intact the antigenicity, which you can use in this case as an antigen to provoke immunity. Immunization consists of 3 doses given at 2, 4, and 6 months, as you have seen in your lecture. Because immunity wanes, so a booster can be given at 10 years, but this does not prevent carriage of the organism in the nasopharynx. Last one of the non-spore formers of all the gram-positive rods that we talk the clinical of clinical importance is the Listeria. Listeria is actually has an interesting pathogenesis. So the diseases is caused by Listeria monocytogenes have a similar spectrum to those by other respiratory organisms, basically sepsis and meningitis. So very similar to what you see with strep pneumo. So, however, it is known to be a very dangerous and targeting newborn, pregnant women, and immunocompromised people. So it is mainly transmitted by, what is the transmission here? Contaminated food. So vegetables, poorly cooked meat, and more is dairy products, non-pasteurized dairy products. So it can cause febrile gastroenteritis. That's the majority of cases. The majority of cases will have this febrile gastroenteritis, and then that's it. But the more important was if it can go through, because of its mechanisms, it can go through the gastrointestinal tract, invade the blood, and then cause meningitis or sepsis. So it's major concern for food industry, along with the others that we have mentioned. Its important property is against relaxed shaped gram-positive rod, formation similar to Corynebacterium, The organism exhibits tumbling movement. Hey, tumbling movement. This is what tumbling movement looks like. So, like a tumbleweed going over and over around. So, it exhibits unusual tumbling movement that distinguishes from other corynebacterium, which are non-motile. So this one has motility. Colonies produce a narrow zone of beta hemolysis, which resembles some streptococci. Listeria grows well at cold temperatures, and storage of contaminated food هاي المشكلة. So you are putting food in cold temperatures to prevent production of bacteria, because cold temperature will reduce bacterial counts or bacteria will not divide. But listeria actually grows well at cold temperature. That's why it's a problem in the food industry. So this is a paradoxical growth, which is called cold enhancement. Pathogenesis. Listeria infections occur primarily in two clinical settings: fetus and pregnant women. So the fetus is a newborn, a result of transmission across the placenta from the mom. In a woman, it's usually, and other immune suppressed adults, usually هلا بنحكي the mechanism. This is a very common organism in renal transplant patients. صراحة, if you look at the literature, we don't really know exactly why, and why listeria especially, and why especially in the renal transplant. But that is actually a problem in many renal transplant patients. So the organism is distributed worldwide, everywhere. It's not limited to one area. It is in animals, plants, soil, and these reservoirs transmitted by unpasteurized milk products, meat, and raw vegetables. Contact with domestic animals, that their feces is also an important source. A very common, this is a zoonotic problem and a foodborne problem. شو قصتها؟ Again, we like to give a scenario. Scenario for this is a person. So what is this scenario that we like to say? عادة scenario is people who are trying to get this fancy food. So they have a spread of cheese and meats. They get these weird cheeses that are unpasteurized because they're looking for the taste. There's delicacies, and this is one way of how you get it. The other, this is the other. After you ingest it, it will appear in the colon and can colonize the female genital tract, and that's how it can be transmitted to the fetus. So the pathogenesis of Listeria, it's an intracellular pathogen. Listeria, its virulence depends on the ability to escape the defenses by sitting intracellularly and then physically jumping from cell to cell. Invasion of cells is mediated by this called bacterial factor internalin on the Listeria side, plus the E-cadherin on the human side. So on our cells we have E-cadherin. Their internalin binds to our E-cadherin and allows them to internalize themselves, so they do not have to go through endocytosis by the cell and have to escape the vacuoles مثلا, or the lysosomes. No, they internalize themselves by themselves. This is how they escape lysosomes. So the ability to pass through the placenta and invade is again against this same interaction. Upon entering the cell, they produce listeriolysin, which is an enzyme that allows it to break away from this phagosome that takes it inside. So from there, obviously, if you do not have well-established cell-mediated immunity, you will not be able to clear this infection. So from here, it can move from cell to cell by what is called actin rockets. So actin rockets, these are filaments of actin polymerization. So they polymerize the actin and they بيعملوا زي زنبرك. So make it very, very tight, and then they release these actin filaments and they cause a propulsion which can propel the cell from one human cell into another. So they can actually, this is how they adhere to themselves. They are endocytosed. They lyse the phagosome. They polymerize this actin. They do this invagination in the cell membrane, and they shoot themselves from one cell to the next, and this is how they do cell-to-cell spread. So if you look, this is the actin filaments by green, and this is the bacteria shown by red, and this is how actually they shoot themselves. Actually, one of the nicer images is these, they can find them. So how they internalize themselves, they form the rockets, and they shoot themselves into surrounding neighboring cells. What are the findings? Pregnancy infection causes premature delivery or abortion. So pregnancy infection causes premature delivery. A newborn infection, this is picked up during delivery and presents with acute meningitis. This is how this is where you see meningitis. So it's a newborn meningitis, usually within a few weeks after delivery. This is very hard to detect based on the mother, as she will still have no symptoms at that point, or maybe just generalized symptoms. Adult infections, immune-compromised adults can either have sepsis or meningitis, so they cannot help themselves against this bacteria from their immune system. So any invasion will show pronounced sepsis or meningitis. The majority of people will have gastroenteritis, which can also be a prodrome of sepsis and meningitis. So, but like we said, the majority of people will have self-limited gastroenteritis as caused by listeria, watery diarrhea, fever, headache, myalgia, abdominal cramps, little vomiting, and then that's it. But then this can be the prodrome of sepsis or meningitis. So normal adults, immune-compromised adults, newborns, all will have meningitis. Outbreaks are usually caused by contaminated dairy products, undercooked meats, chicken, hot dogs, ready-to-eat foods, coleslaw. All these have been also implicated. Lab diagnosis. So it's made primarily by a gram stain and culture. So مع إنه هون exotoxin. So the appearance of these gram-positive rods looks like diphtheroids with a tumbling movement is helpful. They can form small gray colonies with a narrow beta hemolysis on often blood agars. It's confirmed by the presence of this tumbling motility, like we mentioned, and you can, if you want to use mechanized diagnostic methods or normal biochemical procedures, you can do some sugar fermentation tests as well. Treatment and prevention. So if you want to treat this, you want to treat bacteria. This is this is a pyogenic one. This is the only one that is pyogenic. So as meningitis, you want to give trimethoprim with sulfamethoxazole as a combination. Other combinations, ampicillin, gentamicin, حكينا, beta-lactams with aminoglycosides is a great combination, or that with ampicillin with the sulfatri as well. All can be used. Rare instances, this is self-limited and typically does not require treatment. But prevention, there's no vaccine. We don't have a vaccine. So again, do not eat unpasteurized milk products, raw vegetables. You have to wash them. Limit exposure to pregnant women to these sources as well, and farm animals as well. From just to be safe. If you have عادة patients with HIV at certain CD4 levels, they are given sulfatri to prevent pneumocystis pneumonia. This also can prevent listeriosis in these patients as well. هلا خلينا just to cover diphtheroids in the end. These are the aerobic, non-spore forming, pleomorphic, gram-positive bacilli. These are actually very, very common to be present. They don't have the metachromatic granule that is seen and the metachromatic granule that is seen in diphtheria. But they are still arranged in Chinese letter appearance or palisade manner. They are commensals of the skin and mucous membranes. They do not produce toxins, so they differ in biochemical reaction as well as toxin production. They do not have, so they are like, if you think about them, diphtheroids, they look like diphtheria, but they are more innocuous. They are commensals. They are usually found in the skin, in the mucous membrane of the mouth, and there are increasing reports that these organisms can be associated with opportunistic infections, especially in wounds. ويعطيكم العافية. I think this is where we will stop. ويعطيكم العافية.